So have you ever wondered what it's really like to be in the hot seat during a high-stakes surgical board exam? Well, today we're going to give you a front row seat. We're stepping inside a simulation to break down a classic clinical case, hearing from both a seasoned examiner and a sharp candidate. Let's see how they work through it.
All right, let's begin. You have a 45-year-old woman in your clinic. She's found a new lump in her breast. Walk me through your initial approach.
Thank you. My approach would be very systematic, centered on the core principle of triple assessment. This ensures we do a complete and thorough evaluation. So the triple assessment, as the name suggests, has three parts. First, a solid clinical assessment. Second, we move to imaging. And third, the final piece is a histological assessment, which means getting a tissue diagnosis. I'll start with the clinical part. First things first, I take a really detailed history. I'm going to ask about the lump itself, when it started, how long it's been there. I'd also ask about any other symptoms, things like pain or any nipple discharge. And critically, I'm looking for red flags, like skin changes. A full personal and family history, especially related to breast disease, is absolutely essential here. Right after the history, I would perform a complete physical examination. This involves first just looking, inspecting the breasts for any asymmetries or subtle skin changes. Then I would carefully palpate or feel the breast tissue, the nipple area, and of course the axillary lymph nodes in the armpit, all while keeping the underlying anatomy in mind. Excellent. That's a very thorough start. Now, based on her complaint of a breast lump, what potential diagnoses are you considering? What's on your differential list? Well, the list of possibilities for a breast lump is quite broad. As you can see here, it ranges from very common benign conditions, like a simple cyst or a fibroadenoma, all the way to inflammatory issues like an abscess. But the most important thing we have to consider and rule out is malignancy, cancer. We also have to keep less common things in mind, like fat necrosis or a phyllodes tumor, which is a rare one that can be either benign or malignant. And I'm always on high alert for any associated complaints. While the lump is what brought her in, things like skin changes or, say, an eczematous, rashy appearance around the nipple, those are huge clues that something more serious might be going on. And this is a really critical point, a huge takeaway. These kinds of symptoms must always be taken seriously. They are potential red flags for an underlying cancer. This isn't just exam knowledge. This is crucial for safe clinical practice every single day. Good. You've identified the key red flags. So how do you proceed with the next two parts of your triple assessment? Okay, so the next steps are imaging and histology. For a woman over 40, imaging usually means a mammogram, and that's often paired with an ultrasound to get a better look at the lump's characteristics. Is it solid or is it fluid-filled? You can think of imaging as giving us the map of the area. But it's the histology, getting an actual tissue sample with a core needle biopsy, that tells us what the cells are actually doing. That confirms the diagnosis. So, here's the bottom line. While the patient's history and the imaging provide absolutely vital clues, only the histology, that tissue sample looked at under a microscope by a pathologist, can tell you for sure what that lump actually is. It is, without a doubt, the gold standard for a definitive diagnosis. Precisely. So once you have that definitive diagnosis in hand from all three parts of the assessment, what does that mean for creating a management plan for the patient? The management plan is dictated 100% by those biopsy results. For instance, if it's something benign, like a simple cyst, the plan might be as simple as reassurance, or maybe draining the fluid. But if that biopsy comes back as cancer, well, that's a completely different pathway. That would trigger a multidisciplinary team discussion to plan for surgery and potential adjuvant therapies, things like chemotherapy or radiation that help get rid of any remaining cancer cells. So let's just quickly wrap up with the key takeaways from this whole exchange. First, a systematic approach is non-negotiable. The triple assessment is the standard of care you have to use. And you always have to be on the lookout for those clinical red flags. You can really see how having a clear, structured approach leads to a safe and effective plan. This careful, methodical approach really reminds us that surgery is so much more than just a science. It's a craft that truly requires incredible diligence, precision, and a deep sense of care for the person you're treating. Thank you so much for joining us for this explainer. Join us next time as we break down another complex topic.